Good morning, friends. Welcome to Sensodyne Dental Expert Talks, Learn from the Luminaires. And I'm Dr. Ajay Bajaj, and this is our 20th edition of Dental Expert Talks since the month of April. And we've been meeting you regularly and getting different topics. All this while, most of the times we have got you topics directly related to dentistry, or most of the times dentists were the participants. And we're going to do something different. So as we know, there are so many webinars going on, and suddenly I think Kumar sir will also agree that we have kind of run short of variety of topics now. So of course, something related to COVID is always dynamic nowadays. Things are changing every day. And when it comes to immunity-related issues, uh, who can be the best person to talk about is, of course, Dr. Sitesh Roy. Dr. Sitesh Roy has been on dental platform a couple of times before in last 3 months, and we have received probably the best non-dentist personnel who has been coming on dental platform, and he's got the best response so far. People talk about his first webinar on World Dental Association even today, and so we decided to. That was a couple of months ago, 3 months ago, and 3 months is long time in COVID era. So we decided to update our knowledge, the concept, the things which have changed about immunity, and what exactly are we supposed to do, and how we can still protect ourselves and our families. So we have Dr. Kumar Swamy sir as moderator with us, and we all know Kumar Swamy sir. He has been a COVID survivor. He was hospitalized for 10 days. And in spite of all the odds, you can see that Sir has been the most active dentist on the net, online. And I think Sir must have done 30, 40 programs where he's moderating, panelist, or he himself is speaking. And it's been crazy. I don't know how you manage it, sir. There are variety of topics, variety of things, and the kind of dearth of knowledge which you have. So here, sir, I hand over the mic to you, and you can introduce Dr. Sitesh Roy.
Thank you. Thank you so much. Good morning, everybody. Thanks, Ajay. Like Ajay rightly mentioned, 3 months is a pretty long time in today's era. A lot of water has flown under the bridge, so to speak. And even if Dr. Sitesh Roy made such a wonderful impact 2 months ago through a webinar on World Dental Association, he himself, in a preparatory discussion that we've had, mentioned about so much things has changed because opinions, research, data, everything has almost undergone a 180 degrees, at times 360 degrees. So we thought it best to again request him to come this time on the platform of Sensodyne and Bombay Dental Surgical to see how we can now, through a different kaleidoscope, see the changes, if you will. Please allow me to introduce this wonderful, brilliant allergist, immunologist, Dr. Sitesh Roy. The very, very interesting course that he has charted from the time that he finished his MBBS at the GS Medical College. He briefly worked with a very senior, like he mentions, cutting-edge physician involving himself in occupational and industry medicine. He wasn't happy with what he was doing. He wanted to do more. So he went across the 7 seas to the US of A. He did a fellowship in allergy and immunology at the University of Mississippi. He also thereafter worked at 3 simultaneous facilities, which gave him an opportunity to expose himself to the allergic conditions of children and adults alike, which a rich experience. For 14 years in the US, he then decided, I want to go back to my mother India. So he came back, and what probably thereafter was the loss of USA was our gain, as we will see in the next hour or so. Dr. Sitesh has been an author of a 2-volume textbook on allergies and immunology. While in the US, he was voted as the best physician by the survey across the continent for not one, not two, but I think almost 6 or 7 years. And that speaks a lot about his expertise. In India, at Bandra, he is the founder director of Dr. Sitesh Roy Institute for Allergies and Immunology. He also had a decent exposure to the one and only Dr. Nifadkar Center at Dadar when he first came back from the US. Dr. Sitesh, apart from all these achievements, is a wonderful orator and age-defying, if I may add, as you will see. And Dr. Sitesh brings to the table today his experiences and his interpretations of the current conditions related to allergies and immunology. Please, let's applaud wherever you are and welcome Dr. Sitesh to this prestigious webinar. Please, Dr. Sitesh, we are so happy to have you with us. Ajay.
Thank you so much, Dr. Kumar Swamy, for that very kind and generous introduction. And thanks to Dr. Bajaj for inviting me and having me today on your Sensodyne platform once again. And thanks to all the audience who are tuning in on a Sunday morning to listen to us. Truly appreciate it. Thank you.
It's nice to have you, Dr. Sitesh. I know you are traveling and you're not in Mumbai, and you still agreed to come on the show. And it's like real commitment from your side. So let's start with the talk show. And I want to know. I'm a dentist. It's pretty simple. I'll tell you. I went to one of the very popular dental show in Dubai in first week of February. And by then there were 2 or 4 cases of COVID in India. Okay, it was a very small number, meaning there were 2 cases. And by the time I reached there, it became 4. And there were probably a couple of cases in UAE. And the number was very small. Of course, there were many Chinese exhibitors, and China was burning at that point of time. And I thought, oh, it must have been just one more flu, the way we have been listening to some other form of swine flu in recent days, or some bat flu or this and that in last. So there are news which keep coming. I felt it must be just another flu. But as I spoke to you yesterday, and in the 3rd week or 4th week of January on a TV show, you actually said this is not epidemic. This is actually, it has all the potential to have pandemic. We really could not gauge it that time. Nobody could gauge it that time. And we all felt, oh, this is something which is just another flu. But now we know it is not only, we can't just call it a flu. It is much more than that. It has got so many different shades and other things. And one strong connection, which we never really spoken about in life about any disease, was immunity. And that word keeps coming in our discussion practically every day, whomever we are talking with. We come to know, okay, he's young and he's infected and he's in the hospital. And we keep asking, oh, how's his immunity? Was his immunity low? Whether he was having some comorbidities and other things. So what is this exactly? What is the connection? What do you exactly mean by immune system is directly related to this? What is it exactly?
So, Dr. Bajaj, if you think of the immune system, the only right word to describe it would be it's complicated. Just like people talk about relationships. So when I say it's complicated, what I mean is that this is one of those systems that has so many arms, legs, hands, eyes, nose, ears. There are so many systems involved in this, whether you talk about the tissue level, right from the mucosal barriers and our skin barrier, which is part of our immune system and keeps things out of our body, to talking about the cells that are involved in it, which are involved in something called the innate immune system, to what we call the adaptive immune system, in which we have something called T cells and B cells. And along with this, you have an entire myriad. Means even when I did my allergy immunology fellowship at the University of Colorado in Denver, I remember that the CD count, the cluster of differentiation count, was somewhere around 250. And today it has risen to cross 400. So we have so many different immune cells with such a unique marker that we are still learning about, that I still think that we don't understand the immune system completely yet, is how complex it is. But the beauty about it, and if I may show a slide here, which may actually put things in a little perspective. So I'm going to just put this up here for a second so you can see this. Um, So when we talk about the immune system, as I said, it's fairly complicated. When we talk about the features of an immune system, the main thing for this immune system is to differentiate self from non-self. And in that, anything that is non-self, even if it is an organ that has been transplanted, the body tries to fight it off, and hence we need transplant suppression. Same way, if an infectious agent like a SARS-CoV-2 virus tries to enter, it tries to fight it off. And through this entire process, there is a very complicated mechanism. These are all the components. I don't want to bore you with that. But this is literally what the immune system is. If you look at it from the time point on the left-hand side corner, you see the antigen coming in to where finally you have the cells that can kill it, which is called cytotoxic or killer cells. And you have the antibodies, which can also neutralize the bug or the virus or the parasite or the infection or the fungus, whatever it might be. It's a very, very complex and intricate mechanism that our body mounts. And so when someone says that I have a healthy immune system, we can't just assume that it is one thing. It's a conglomerate of all these things that makes a person respond appropriately, because there are many things that can go wrong with this system, as you can imagine. If you respond to an internal threat, then you get an autoimmune disease. If you respond to an external threat, which is not really a threat, what's called an overreaction, then you get an allergic reaction. And if you want an appropriate reaction to an internal threat, the example is a cancer cell that is forming. We all have cancer cells forming in our body every single day, and our immune surveillance selects these cancer cells out very, very successfully and removes them from our body in a very smart way on a daily basis from a very young age onwards. Because whenever you have a factory that's producing millions and billions of cells, there are going to be some defective cells that are formed, call them cancerous cells, which have to be removed. And when you have the same thing for an infection, it's a good thing with an external threat. So in this whole scenario, this is kind of a short understanding of what really happens the immune system and what it's doing. And I hope that that gives a brief overview to you of the cellular immunity, the humoral immunity, which is the antibody immunity, the cells that are involved, and also what we call the cytokines, the interferons, the chemokines, and the various signaling chemicals that are involved. So where most people shy away from immunology in the second year of medical school, when we have a textbook that's very narrow and small to study, I got very interested in how fascinating it was, and I went greatly into its depth, you can see, and where I am today. So this has been my passion from second year of med school, and I still think very fondly about it and work with it in different scenarios, whether it's allergies, infections, or autoimmunity.
So I understand it's an ocean, and probably we will try to just test some of the drops of it. And but coming back to the immunity, what are the common conditions that result into low immunity? Meaning we talk about we should be boosting our immunity nowadays, but there should be some conditions which we should be avoiding, right? And what are those conditions which we should be avoiding on a regular basis? That, okay, these are the times, testing times, and our immunity should be adequate and it should not be on the lower side. What should we be doing?
So I think when we talk of a weak immune system, I get a lot of patients who come to me saying that my immunity is weak, and their most common presentation is that they've been having infections again and again. So it is estimated that a small child in the first 3 to 5 years of life may have up to 6 respiratory tract infections a year, and that's considered normal. Okay. That's if the child gets over the infection within a week or so. If the infection is prolonged, even in a child who's getting 6 infections, it's not normal. So the easiest way that people know that their immunity is weak is by recurrent infection. Some people get sinus infections again and again. Some get respiratory infections. Some get skin infections. Some get internal abscesses. So this is what we call primary immunodeficiency, where there is some component of the immune system that's not working okay, and that is generally an inherited type of a disease. And these people do need to see an immunology super specialist, have their immune system evaluated. We have ways in our practice where we evaluate innate immunity, we evaluate cellular immunity, we evaluate humoral immunity, we evaluate how the immune system responds to all of these things, and we also do a very careful evaluation of response to vaccines and other things. Now, when we talk about other ways in which the immunity becomes weak, the commonest example again would be a newborn baby who is born, who still hasn't developed their own immune cells. And there, the mother's breast milk is their best friend because it has a variety of immunoglobulins, variety of cytokines, variety of other chemicals that are invaluable for the baby's immune system to develop. Within the first 3 to 5 years, they get exposed to a lot of things, first indoors, then outdoors, and their immune system balances out and they are healthy. Later on in life, if you ask me one factor which affects our immunity the most, I would tell you our diet. Okay. Because these days, with the amount of refined foods, processed foods, ready made foods, sugar and sweetened foods that we consume, all of these tend to affect our digestive system. And remember, our gut is where 70% of our immune system resides, in the Peyer's patches and in the variety of lymphatic channels and networks that are there in our liver, our spleen, our gut. And so the most important thing when someone asks me, and even in my practice, when someone tells me, Dr. Roy, I want to make my immunity stronger, I actually have diet counselors on my team that they meet. We study their diet, their lifestyle, their genetics, their likes, their dislikes, and we give them a diet that they should be on, which is customized to reduce inflammation in the body and enhance what we call the acid-base balance in the body so that the immune system can work very well. And in this process, the next big factor is lifestyle. So in our lifestyle, we are all, as I can expect, living in Mumbai under a lot of stress all the time, whether it's the stress of traveling from home to work or getting back or achieving all our targets and responsibilities that often we set for ourselves. We sometimes don't get adequate sleep. And even if we sleep, we don't sleep well. So the quality of our sleep is not good. And so all of these factors also affect our immune system and can influence whether it's working at its best or not. Besides this, the hormones that we have. So as a person ages, there is something called immune senescence. And that is why with COVID-19, what we are seeing is that people above the age of 50 or 55 or 60 or 65, depending on the studies you're seeing, but it almost seems like 50 seems to be the cutoff above which people might have more problems than a younger person. Having said that, we've had children and young adults also get very sick and some even die from this infection. So I'm not saying that they're completely immune, but with age, the immune aging that occurs of the cells and the number of what we call diversity of the cells, the repertoire of the cells and the antibodies tends to decline. And that again makes a person's immunity weak. And that is why it is so important for people who are in the older age groups to, from time to time, get a self-check and evaluation, and if needed, even visit a super specialist to know how their immune system is doing and what they need to do to make it better. Besides this, we have all heard that diseases like diabetes, okay, because diabetes being a high sugar disease, it brings a lot of chances that an infection can thrive longer and better in the body if you were to catch it. Hypertension and heart disease, because again, this puts a constant strain and load on the immune system and the body in general. Autoimmune diseases, diseases that affect, so bad allergies, asthma were thought, COPD, respiratory diseases, interstitial lung diseases. These all would make a person's immune system a little weaker than it normally would be in a person of a similar age who did not have those diseases. So chronic diseases, age, there has been very interesting data that women and girls who are in the age group where they are still having their menstrual cycles properly, and they have enough estrogen and estradiol in their body, they tend to have less problems with the COVID infection. And this ratio has been shown across the globe, that the ratio of male to female for COVID-19 infections is somewhere around 60 to 40 or 65 to 35. Or in a place like India, the ratio is 68 to 32, where 68% of the patients are male and 32% are female. So even the female hormone estrogen, and interestingly, there are trials going on in the world, which was really fascinating to me as an immunologist, where they are trying estradiol patches applied to men to see if their immune system can be deviated in a more protective way, so that their innate immune response is better. So women naturally have the benefit of a better innate immune response than men do. Now add to that, the men are more likely to smoke, more likely to drink, more likely to take more stress, more likely to have more high risk lifestyles. You can understand why they would get the infection more. So, but these are all the factors that go into a strong or a weak immune system. But the biggest thing for a weak immune system that a person needs to understand is diet, lifestyle, sleep, and then obviously exercise. And I think even related to that, I might have a slide that I had kept in, which I'll just see if I can share, because it kind of summarized the various things that go on with our immune system. And this is where, the whole talk of diet, lifestyle, health, vitamins, exercise, sports, workout, meditation, sleep, everything comes in. And it's really a fascinating process again to see how that works.
Yeah.
I know that's a long drawn answer to a simple question, but I don't know how else to answer that, frankly.
Viewers, an expert is one who gives you the answers before you can ask them the question. Yeah. That's exactly what Dr. Sitesh has done. He knew exactly what would be the next question. So he answered so beautifully as to what is an immune system, what are the factors which lower, what are the factors which probably can prop it up. Dr. Sitesh, you spoke about the percentage of male to female predilection of COVID. I will slightly change that into Pati and Patnis. And what, in your opinion, which of the Patis you think has worked well in this COVID condition? The homeopathy, the allopathy, the sympathy, the piti, or the Tirupati? Which one do you think has worked well?
Very nicely put, in a very Dr. Kumaraswamy way, as I can say. I can see your personality shine through that question. So it's a very loaded question, as I may say. I am a believer in all pathies, though I am a hardcore allopath by training. This is my 30th year in the field of modern medicine. I would still say that a lot of what ancient medicine has to offer truly is where real prevention begins. So all the ancient medical sciences, Ayurveda, Siddha, Unani, Tibba, Chinese medicine, Japanese medicine, their entire goal was truly on prevention. So keeping your immunity boosted and strong, recognizing that there is what I call an invisible microbial world around you, which people have ignored all these years. Till COVID-19 came, people never cared about what was there in the parcel that they received, or where they were touching in public places, or what a hand sanitizer was, or what was the importance of washing your hands before eating. Nobody looked at that. And I think that ancient medicine began its theories. And if you look at the culture of India, when you come from outside, you remove your shoes and chappals outside, you wash your hands and your feet, and then you enter the home. I think our Rishi Munis were wise and sages long before we woke up to what the immune system and what the Jeev Shrishti, as I call it, the hidden microbial world around us is. So I feel that in that sense, the true answer to what is working lies in there. So as I mentioned, the right utilization of the natural herbs, the natural spices, the natural foods that we've always had is the first step to keeping a healthy immunity. And I'm sure you all have been bombarded by messages saying that you should drink hot lime water every 15 minutes throughout the day. I don't know what that would do to your kidneys and your gut. I don't recommend that, but I'm just saying from that extreme to steaming 4 times a day, which again, I don't know, it seems like a lot. Maybe once a day may not be a bad idea, especially in rainy season when anyways our respiratory system needs help. Um, to utilizing the actual pathies, as you rightly said. So, in the homeopathy field, my homeopathy colleagues whom I interact with have really had very strong feelings about arsenic album. They've had strong feelings about camphor. They've had strong feelings about certain other homeopathic regimens which, if given in a preventive way, they believe have helped lakhs of people. Now, I am not a homeopath, so I can't comment on that. And I have, as I said, faith in all the pathies, but I really believe that somewhere there is a truth that each of us needs to assess, weigh the risks and the benefit, and decide what works. Same with the Ayurveda system or the Unani system. There have been Chavanprashas that have been recommended for people to have. There have been herbs, tulsi, neem, we have known for thousands of years. We pray to them if we are Hindus, knowing the many benefits that they have on our gut, our immune system, our respiratory system, and utilizing those on a preventive basis. People have designed kadas with them. I'm sure many healthcare professionals have heard Sri Ravi Shankar, or have heard Sadhguru, or have heard other people talk about the different preparations, have heard Baba Ramdev talk about the different preparations. I think the biggest thing that modern medical professionals say about all this is we don't have trials to show us which work, which don't. It's very hard to do a placebo controlled trial with curcumin and turmeric, in COVID 19. Though we know now the whole world accepts that curcumin is a great molecule and it has immense anti inflammatory properties and antibiotic properties. But will it be the single agent that helps us fight COVID 19? That trial is still not done. So I think somewhere the way I look at it is that we really have to find again the balance. And here again, I will just quickly project a slide which I had also shown in my previous presentation, and it was beneficial to a lot of people. So I'm just trying to see if I can get to that slide. Um, Are you all able to see the screen being shared right now?
Yes, yes.
Some reason it's not letting me go to full screen mode.
No, even I can see that. You can just escape once.
I think it might let me do it from here. Let's see.
You're full screen now.
This is on full screen, but it won't advance the slide for some reason. Okay. All right. This was a slide in which I actually showed some of the Ayush system of medicine, what they suggest. So drinking lukewarm water, certainly, we are so used to having cold drinks, ice cream, sodas, and we don't realize how cold liquids and solids lower our immune system. They lower our mucosal immunity in our respiratory tract and make us prone. And I'm sure you all have seen, I have seen thousands of patients over the years who've said, if I eat a couple of ice creams, I catch a sore throat, I get a bad cold. There are many factors that go into that. Certainly, practice of yogasanas, pranayama, and meditation makes a huge difference for calming the mind, because, as I said, stress is a huge suppressor of the immune system. And the more stressed we are, the more we worry, the more we take tension, the more we live in fear, the more these problems affect us. You would see use of spices like haldi, jeera, dhania, garlic, eating lighter food, easier to digest food, getting good hours of sleep. So really our ancient sciences in every form and fashion have always told us to have what I would call a balanced lifestyle. And from that end, when we come into the allopathy side, the biggest change that has occurred between my last chat with all of you all in May and now is that we have two antiviral drugs. One is called favipiravir and the other is called remdesivir. Favipiravir is approved for mild to moderate COVID-19 infections, primarily outpatient use. And remdesivir is for inpatient use, again in moderate cases, maybe going into even severe cases. And both of these agents, they have been what I would call reasonably effective. I'm not like saying that this is the final answer, this will take care of everyone who gets the infection. But we have certainly seen that they can reduce the viral load because they are RNA dependent RNA polymerase, something called RDRP inhibitors, both of these drugs. And given early in the infection, from the time of presentation, they reduce the duration of the illness. They reduce the speed and the efficiency with which the person spreads the virus to others by reducing the viral load. And ultimately, they can prevent hospitalization and even prevent progression to severe disease, which is the last 5 to 10% patients who require ICU care and require very, very acute critical care. So that when combined with the anti-IL-6 drugs, so there has been something called tocilizumab and something called itolizumab, both of which have shown benefit in preventing the cytokine storm, where, as I said in my earlier slide, when the immune system overreacts and it doesn't know where to stop, it can end up harming itself. And in that process of harm, these drugs are very beneficial in potentially saving lives in those situations. So I think in the whole spectrum of things that we have spoken about, right from diet, lifestyle, exercise, sleep, to using preventive natural herbal preparations, to utilizing therapies at the earliest stage, to testing at an early stage to confirm the diagnosis and then getting on the right medications is really the key by which we have now seen the decline in the fatalities, the decline in the hospitalizations. We now do have some ICU beds that are free, which were not free maybe a month ago. So I think that somewhere we are starting to make progress, and certainly vaccines are moving along really fast.
Yeah, absolutely. So we will come to vaccines, very important topic. Right now, the hot word. You have been repeating one word again and again, and that is sleep. Okay, so let's consider the scenario that I get up in the morning. I may be going to the clinic. I may go, say, alternate day to the clinic because there are no enough number of patients, or some of us are still not going to the clinic because we have seniors at home who have health issues and we want to protect them. Or for I myself may be having some health issues, so I may not be going to the clinic. And then we exercise a bit. We have kadas, we have steam, we do everything. But by the end of the day, I go on Netflix, Amazon Prime, or whatever, Hotstar, and I will be awake till 2 o'clock, 2:30 in the night. I start with a web series, and what I don't remember, 2 o'clock, 3 o'clock, 4 o'clock, I will sleep. And next day, I will get up at 9 o'clock, 10 o'clock. I'm completing my 8 hours sleep. Good, is that okay? And I will binge on wafers and whatnot, because if I'm going to be awake till so late, I'm going to feel hungry after, say, like I have had my lunch at 9:30, 10, so I'm going to feel hungry after 3-4 hours. So is that a good thing? Is that, because this is a routine for the majority of us, isn't that right?
It's true, and I certainly see my share of patients in my clinic. I also counsel entire families, so very often one family member who has an allergy or an immune problem or an other issue comes to us, and soon the whole family becomes a follower and wants to know how best to keep themselves healthy. So as you said, the younger kids in the family might be on their phone with their friends, chatting away to the wee hours of the night. On Facebook, on FaceTime, they may have friends across the globe who are in another time zone, and parents might be on their web series or their movies, and they're catching up on all the years of missed time when they were working so hard and didn't have time to watch what they wanted to. So in all of this, it's not the total hours of sleep. It is when you get the sleep that matters the most. So our body is integrally connected to the sun, whether we like it or not. Okay. Now, the sun has a very specific cycle, and you will see that Mother Nature, right from the birds that tweet in the morning to the cock that crows in the morning to the birds finishing their chatter in the evening and going to sleep, it's all connected to the cycle of the sun. Now, we are not anything unique. We may think that we are very evolved and great people, but we are still animals to the core. Okay, we are animals to the core. And those animals are driven by the cycle of the sun, whether we like it or not. There is a gland in our brain, which when I was a medical student, we were still being taught that it is a vestigial organ called the pineal gland. Okay. It is still written in textbooks that it is believed to be a vestigial organ. The very smart neurophysicists, neuroscientists, neurosurgeons who have studied the pineal gland have realized that even if you keep a person in a completely dark room for days together, his pineal gland knows when the sun has risen and when the sun has set. It is connected to that cycle. Okay. Large majority of what I call the growth hormones, the immune boosting hormones, the reviving hormones are produced by our brain and our endocrine system between the hours of midnight and 4 a.m. Okay. So if you are not asleep, I'm not saying trying to go to sleep. I'm saying if you're not asleep between 12 and 4, even if you got extra 8 hours of sleep during the daytime, you cannot recreate what your brain and your endocrine system will produce in those hours. Oh. And so what ends up happening is, after all, body is a machine. We will use it, we will then abuse it, and we will abuse it till the nth degree. And then we end up with a big disease like diabetes, which is now associated with lack of quality sleep, by the way, or with heart disease, which is also associated with lack of quality sleep. And quality sleep happens to be sleep had between the hours of, let's say, 10 or 11 p.m. and between 6 or 7 a.m. in the morning. So I think that anyone who wants to have a healthy immune system is going to have to respect. Now, once in a while, if you party or break a rule or do something different, your body, as I said, is a machine, can handle it through the wear and tear. But if it becomes a habitual routine, then certainly you're putting your body, your mind, your peace of mind. Your people have found that if you don't get sleep in the hours that you get most rest, the deepest sleep, then you end up being more restless or more anxious or more stressed the next day. The chances are you'll be producing more cortisol the next day. All of this affects how your immune system functions eventually, how your gut digests your food, and that's where all the diseases begin. And so, like you have pointed out, it is not getting 7 to 8 hours of sleep from maybe 3 a.m. in the morning to 10 a.m. or 11 a.m. in the morning, but it is getting even 6 hours of sleep at the right time in the night, when nature, Mother Nature, we are not as so. I when people ask me what is the biggest thing that COVID-19 has taught the world, I said, to show us how puny, how flimsy, and how weak we are in the face of nature. Means one little virus which you can't even see, have to put it under an electron microscope to see, which came from bats. And by the way, bats don't die with coronavirus. Okay, bats survive, coexist with coronavirus. They get sick, they spread to other, because the virus doesn't want its host to die. The virus wants its host to live. We are so weak that we can't survive it, and it's killing us off. So we have to realize somewhere that though we are the most evolved species on the face of this earth, we also happen to be some of the most fragile species on the face of this earth. And respecting Mother Nature is a very, very important thing. And I actually guide and counsel people in meditation seminars. So I do seminars for doctors, for healthcare professionals, for general public. I have an entire team with whom I do these. And in these seminars, we teach people about right diet, right lifestyle, right sleep, right meditation, right mind management tools, technology, whatever you want to call it. And I feel that becoming aware about that is a very, very important factor to keeping ourselves healthy. Going back to our roots, to our ancient culture, we've become too westernized. It is the top reason for rise of diseases, westernization of diet and lifestyle. Where did these web series and all come from? They are not a creation of India. They are all a creation of the West, and we are only mimicking them. Whether it is our different systems that we still follow, and that is why Independence Day being yesterday, I always tell people, ask yourself, are you truly independent? Are you still following everything that the white culture gave you as the core and the principle of your life? And you'll realize that it is, whereas our ancient systems were way smarter than that, way smarter. Go back to the roots.
Friends, if you actually heard him between the lines, do you need more reason as to why he came back from the US? Because he is so strongly convinced and rightly rooted in our systems and values. And if you still have doubt, just look at him. He is one person, I'm sure, practiced first and then started preaching. And that's why he looks so intelligent, clear in his thoughts. And of course, God bless, like I mentioned earlier in the introduction, age-defying. Sitesh, coming back to, allocating the blame, so to speak, is respiratory system the favorite whipping boy of allergies, or is it other systems of the body too, which, allergies, as we understand, there has to be probably a cause and an effect. So just take us through this myriad, which you have attempted earlier, but which system is actually at the receiving end?
Right. So I think worldwide, if you look at statistics, probably the respiratory tract and the skin, the cutaneous system, are the two biggest areas where allergies affect the most. It is estimated that about 15 to 20% of the population in India has some form of respiratory allergy, whether it is allergic rhinitis, allergic rhinosinusitis, allergic asthma, allergic conjunctivitis, allergic causes for their otitis media and other issues. So the respiratory and associated systems around it are probably the biggest brunt. And when you think of allergy, again, it's the same kind of mechanism where our own immune system, instead of tolerating a dust mite particle or tolerating a pollen or tolerating a protein that came from a cockroach or a cat or a dog, which have been around us for millions of years, it decides that it's an enemy and starts fighting it and reacting against it. And in that, we end up having symptoms. And so the same systems that the COVID-19 infection gains access through. So it gains access through the eyes, the conjunctiva. It gains access through the nose and the nasal mucosa. It gains access through the mouth and the oral mucosa. It gains access through the respiratory mucosa, the gastrointestinal mucosa. The same areas are where allergies also affect. And so from head to toe, we have ocular allergies, we have nasal allergies, we have oropharyngeal allergies, we have lung allergies, we have food allergies, we have drug allergies, we have so many different, we have cutaneous allergies, which is called atopic dermatitis or eczema. Following that, you will end up with something called urticaria, and it is estimated urticaria, which is hives, something that 1 out of 10 people will have at some point in their life. That's a very high figure. So if you have 7 billion people in the world, you can assume that 700 million of them at some point in their life will have urticaria. Okay. And in urticaria, allergies and immune causes are at the top. So allergies truly have a very wide target, a very wide range through which they work. And even with COVID-19, initially there was a concern that people who have not well-controlled allergies and not well-controlled asthma suffer more if they were to get a SARS-CoV-2 infection, which is true. And we urged all our patients not to stop their anti-allergic medications, their nasal steroids, their inhaled steroids, their therapies. And we even told people, many people have flare-up of their allergies in the rainy season, because the rainy season is where mold, fungus, and dust mite allergy is at its peak, and many people have respiratory issues. I have calls every day from new patients and old patients that we are having sneezing, coughing, and a low-grade fever. Are we having COVID-19? And in most cases, it is their allergies that are bothering them. It's not COVID-19. We obviously still have to rule it out, because in pandemic times, you have to rule out the thing that can be most dangerous. But many of them, we do a simple allergy skin test, or we do certain specialized blood testing that we do as allergists, and we're able to identify and take care of it. So The skin and the respiratory tract, I would say, are the biggest ones, but it all begins again in the gut. It all begins in the gut. Even sensitization to some of the skin allergies begins in the gut. So I think all the mucosas are very interestingly where allergies affect most.
That's right. Uh, so what is the exact connection that we can set in? Like for example, how are we going to take more care of ourselves from these allergies during these days? And will there be, if I'm more exposed to allergies, and is there a more chance that I will have severe infection of COVID?
So interestingly, in order to protect oneself from allergies, the only way to know is if a person is having any of these eye allergy, nose allergy, food allergy, respiratory allergy, skin allergy symptoms, they really need to see an allergy immunology specialist and get themselves allergy tested. Because once you know what you're sensitized and allergic to, then you can do avoidance. That is the first step of keeping ourselves safe, is identify the problem. If you know that there's a problem, only then you can identify it. And we as allergists, we also do something called immunotherapy, where we desensitize people from their allergies. It's a slow process, a long-lasting process taking a couple of years, but at the end of it, a person may be free of those allergies completely, which is really a phenomenal thing. Besides that, what was the second part of your question? You had said, how do we protect ourselves? And there was one more thing you said.
Which are the more important allergies which I should be looking at during COVID times? Is it respiratory allergies or any type of, like as you said, ocular allergies or skin allergies? Which should be more worried about? And is there a direct correlation? Meaning, if I'm asthmatic or if I have respiratory allergies, will I be more
at risk?
More at risk? Yeah, so I'll answer that. So initially there was a thought that having allergies puts a person at greater risk for catching COVID-19. That theory has not panned out now that we have data from across many countries around the world. But having asthma that is not under control. So if someone has asthma and they are on medications, they are on their inhalers or their dry powder inhalers, and they're well controlled, then their risk is no different than a person who doesn't have asthma. But if someone has poorly controlled or not well controlled asthma, then their risk, if they catch the infection, because any respiratory infection, we have known this for now at least 4 decades, that catching simple influenza, we are in the influenza season right now, and I hope all of you all have got your flu vaccines, because influenza is a very big trigger for asthma flare up. And it has been known historically, and that's why from the 80s or 90s, all people with asthma are recommended to get an influenza vaccination once a year, because the virus changes itself, the vaccine changes itself. The other factor that has been very interesting, some people have even come up and tried this theory out in some small cohorts where they felt that if you have allergies and you're on inhaled steroids and nasal steroids, your chance of getting COVID infection is actually lower because you have less inflammation in the tract and your tract is healthier and you may actually not get. So getting the right diagnosis, being on the right medication actually is protective. And not getting the right diagnosis and not being on the right medication can actually increase the risk of getting the infection. And then possibly the severity, there has been no correlation that someone with asthma will have more severe disease. That's not been done. They may have more problems due to the disease, because any respiratory viral infection can worsen bronchospasm, which is the key feature of asthma, with coughing, wheezing, shortness of breath. Very similar symptoms to what you can expect with COVID also. So in that whole process, what I would say is, if a person had these problems even before COVID times, since childhood or since teenage years or through young adults, please go in, get yourself evaluated, get yourself tested for allergies, get your tested for the lung functions and other things that need to be done. Identify the problem, get on the right treatment. There are very safe treatments these days that we as allergy asthma specialists do for our, and I see pediatrics and adult both. I've seen womb to tomb cases, literally is how I see in terms of age groups. And there are very safe medications and they can make a difference in preventing a person from getting COVID infection.
Sitesh, pardon my ignorance. if at all we go back to our directories, medical directories, we sort of categorize specialists. And today, if I were to ask you, super specialty of allergy and immunology, how many of the specialists are around for us to actually go and knock the door? Or if there is a second substitute, if you cannot find an allergist, at least go to B.C. physician. If you can kindly highlight and enlighten us as to where would we find an allergist or immunologist?
So we are a rare breed. So there was, when I first came back to India back in 2011, there was not even a single fellowship training program in allergy immunology in India, not a single one. There was a certificate course and there was a diploma course, which was a long distance diploma course. I have been associated with all of them in training the next generation of allergy specialists in India.
Wonderful.
And we have now close to, I would say, 1,000 physicians who have some specialized training in allergy and immunology and asthma. Though not all of them are what I would call fellowship trainees. Fellowship trainees are still very few in India, but the people who have also done a diploma course do a very good job in identifying, diagnosing, testing, and treating the cases. We are, the MCI finally, I believe, gave the approval to have an allergy immunology course just last year.
Wonderful.
After a lot of efforts from a lot of good people who are quite senior.
Came actually.
So hopefully there will be more programs in the near future where people can train. Who are the other physicians you all can see? So chest physicians, pulmonologists, take care of asthma, and they tend to have a pretty good in-depth knowledge about asthma and respiratory diseases, and they can do a pretty good job in many of the postgraduates who join our diploma training courses in allergy and asthma are either from the background of ENT, ear, nose, throat. They're from the background of pediatrics. They're from the background of chest medicine or pulmonary medicine. And some obviously from MD medicine. So these categories of physicians certainly have a bit more refined, advanced training through which they can give good guidance. But really, I think allergy immunology is still a very super specialized field where it depends on the physician and their interest level in taking care of those cases that determines how much they self-educate or attend, at all the national programs, I conduct workshops on allergy training where we sensitize people to skin testing. We sensitize people about immunotherapy and how they can potentially get rid of certain allergies. So we are doing our part, and I believe that there is a lot more awareness now in 2020 than there was in 2011. Or even prior to that, when I used to come and see patients in my friends' clinics when I would visit back from the US, I think things have come a long way. India certainly has a lot of options when it comes to medications versus limited options that are there under patent in America. So we have our advantages and we have our disadvantages. But yeah, it's
sorry to interject.
Yes.
The reason I'm smiling is majority of us and our viewers had put allergy as an optional topic to study. Remember when you were studying, ये option में डाल देते हैं. And here you are a specialist in that. That was the reason I couldn't hold myself back. I said that makes the difference between the ordinary and the special. Yeah, please go ahead.
I don't know if I'm special. I think I was different is how I look at it. Like I said, most of my batchmates, my colleagues, in the entire field of microbiology, immunology was such a small part in our MBBS curriculum, such a small part. And within that also, you could count on the number of questions that they would ask you, if at all any, on your boards. And I still read the immunology section of the textbook and the immunology textbook on USMLE 3 times because I was so fascinated by that system that I said, it's amazing. There is no other system in the human body that has so much flexibility, malleability, ductility, whatever you want to call it as the immune system. There is no other system in the body that can do that. And it just fascinated me. So I'm different. What you described, you went through was the standard. That's how most people are. And you do well in your exams. You don't have to study those things because you never get questioned on it. Even today, when I look at the asthma section in exams and curriculums, it is so small. Whereas it's estimated 7 to 8% of children in India have asthma, 2 to 3% of adults in India have asthma, and yet asthma is not treated as a separate specialty, as a separate problem. It's just run of the mill. What's being done, we are still using theophylline. I don't remember the last time I used theophylline in America. So there is a lot of physician education. It's happening, and many people are doing their part. I'm not the only one. And I think it's all towards a good purpose and a good reason.
So viewers, we know that your Dr. Siddesh is different. If you remember, just half an hour ago, he mentioned that he's been into his practice since last 30 years. So you can guess his age. And he just doesn't look of his age. I'm sure he must be following all the things which he's been speaking to us, right? All the pathies which he must be following, including I'm sure Ayurvedic to spiritual to other things. The kind of lifestyle he must be leading, and that's how he still looks so young. Meaning, it doesn't look that he's been into practice for like 30 years now. That's like really, really long. So it is all the game of antigens and antibodies which is going on in our body throughout the day, all the time, whether we are awake or we are sleeping. Okay. So what is the role of antigen antibody in detecting this SARS-CoV-2 infection virus nowadays?
So the most important topic in this entire SARS-CoV-2 and COVID-19 story is the detection of the infection. So when we say antigen, we are talking about a protein or a glycoprotein that is a part of the virus that our body recognizes as being foreign, as being alien. Okay. And once that alien particle has entered the body, our body, as I said, first mounts an innate immune response with something called natural killer cells, macrophages, dendritic cells. And in the second phase come what is called the T cells. The T cells are lymphocytes, white blood cells, which we know in COVID-19 infections, people have a reduced white blood cell count and their lymphocyte count drops. And actually their neutrophil to lymphocyte ratio goes above 3.1, 3.2. And it's one of the features of COVID-19 infection. So these lymphocytes recognize the virus and they start a repertoire of forming antibodies. Antibodies are protective proteins that our body makes. There are different classes of antibodies. There's something called IgM. IgM is the first antibody that is formed against any infection, whether it be a bacteria, a virus, a fungus, or a parasite. IgM comes first. Then there is something called class switching that occurs. And in class switching, there is something called IgA, which is specific to the COVID-19 that is formed. This IgA goes and coats our respiratory tract, coats our digestive tract, coats are what we call mucosal surfaces and becomes a soldier, a guard that will quickly trap the virus when it tries to get into the body and remove it from getting into the cell and causing an infection. And the other antibody that it class switches to is something called IgG antibody. And this IgG antibody is what is the long-lasting antibody. You can call it, so you can think of the innate immune system as, let's say, the policeman who comes first on the scene of the crime. Okay. And you can think of the highly differentiated, highly specific neutralizing antibody as the black cat commando special ops that arrive at the scene of crime to actually get rid of the infection ultimately. And between that, you have all the other things that would be there to try to limit the virus from entering the cells. If it has entered the cells, damaging the cells so that it can't replicate and make more of itself, and then ultimately removing it from the circulation and the body. So antigens, part of the virus, antibody, part of our immune response, are the biggest key in this whole process. And obviously there are very specific, what we call cytotoxic T cells that are also generated, which become very specific to the virus. And why these specific T cells and B cells that produce antibodies are important? Because that's what gives us memory immunity. So that if you recover from the COVID-19 infection, there have clearly been people who have gotten reinfected even as early as a month after the first infection. Okay. Some have gotten infected 2 or 3 months down the line. But what ends up happening is if your memory immune response is not strong enough, after some time, your body will forget how to fight that virus, and then you become susceptible to the infection again. And so, knowing that you're immune and knowing that your immunity is sustained is one of the good things that helps people know that their body is moving on the right track.
Okay. So there are two questions which come to my mind. If I am a COVID survivor, should I always be afraid that I can catch the same infection again? And how long will that take? Meaning, I have to be careful for the time this pandemic is going on. And second thing, if I'm a COVID survivor, uh, whenever the vaccines are available, shall I be taking vaccine or no?
Okay. Let's take one question.
By the way, that was my question.
That's three loaded questions.
I'm sure, because you are a COVID survivor, so it is so important for you to notice.
So let's take the first question. If I have had COVID, should I be scared of getting COVID again? The good news that we have from previous coronavirus infections is that we know that at least for a 3 to 4 month duration, majority of people, greater than 90% people, will have a fairly strong immune response and memory. Okay. Now, beyond the 3 to 4 month mark, as you have to realize, publications of people who got sick in Jan and recovered in Feb, and then the research paper was sent for review and correction and published in May. We don't have data of 8 months. We have data of 3-4 months. Okay. We have to realize that a small percentage, maybe 5, 10, 15%, do seem to decline their antibodies faster than other people. Now, who is in that category is very hard to know unless you're doing repeated antibody tests and tracking them every 4 weeks or 6 weeks or 8 weeks. You would not know. So what I tell my COVID survivor patients is that you have to take the reasonable, appropriate precautions. What do I mean by reasonable, appropriate precautions? Just because you had an infection, that doesn't mean you can walk around without a mask now. Just because you had an infection, that doesn't mean you don't need to sanitize your hands if you touch a common surface, or you don't need to wash your hands with soap and water after contact with people or places or things. It does not mean that you should not be physically distancing yourself at least 3 feet while talking to people, and at least 6 feet if someone has any kind of respiratory symptoms, preferably more. So those reasonable precautions need to be followed even by a person who has had COVID infection. Whether mild, moderate, or severe does not matter. You need to take the precautions. And these precautions, in my opinion, are going to be around for a while. Now, what is a while? Is it 6 months? Is it 1 year? Is it 2 years? Even I don't know the answer, because everyone is scared that when the western regions of the world go into their winter season starting from October, November, whether there'll be a huge spike in cases again, because winter is known to be the season for viruses. The existing coronaviruses, the HKU1, the NL63, the OK43, the different ones that are there, those are known to cause common cold in the winter season, and they mutate. And we have found that the old coronaviruses provide some protective immunity for up to a year or a year and a half after the infection. But after that, it seems like the risk goes back to where it was. Wow. So recognizing that, I do believe that people who have had the COVID infection also should consider getting the vaccine when the vaccine is available, provided that they may not be the first people in line to get the vaccine compared to someone who's never had it, but they can be the 5th, 6th, or the 10th in line to have the vaccine when it's available. And they could even wait to see how the vaccine is doing in other people, because clearly the vaccine will be released with a study of 30, 40,000 people. And what you really want is lakhs of people getting the vaccine before you get it yourself under ideal circumstances. So the person who's a COVID survivor might choose to wait a little bit before they get the vaccine. But eventually, vaccination is going to become a part of the protocol And it might even require repeat vaccines, whether in a year or 2 years. We still don't have the data. That is still in phase 3 trials are going on for 6 of the vaccines right now around the world. There are several that are in phase 1 and 2. And as you know, there are over 160 potential candidates, 200 according to some publications, that are in preclinical or early clinical phases. So it's a matter of time, it's a matter of patience, and it's a matter of taking reasonable precautions, whether you've had the disease or not, in protecting yourself. That would be my answer. Does that answer your question?
Yeah, of course.
Dr. Kumar Swamy, do you have specifics, anything that I did not respond?
No,
that you...
So in continuation with what you just mentioned,
Correct.
As a COVID survivor, you are so on the point to say that this sort of complacency which sets in, that now I cannot get affected. But that's the most dangerous thing, because you're now letting your guard down. So even if it is not COVID, you are now open to probably other infections, because your resistance could be low, immunity could be low, because of all the medications which you have received. Having said that, is there a silver lining to say that, can I be a plasma donor in a philanthropic way of helping some deserving patient? And if so, what could be the parameters and what boxes do I need to tick?
So certainly a person who's gone through a COVID infection and has what we call reasonably high titers of antibody. So I have seen people with titers of 28, 30, and I've seen people with titers of 1, 2, and 3. So the higher the titer, that doesn't mean that all the antibodies are going to be what we call neutralizing antibodies. And it's really the neutralizing antibody titer, which when tested can tell us whether the person is a good plasma donor. In India, that extensive testing is not being done. In other parts of the world, they're actually looking at the titer to be at least 1 to 640 or 1 to 320. That's the titer we look for. The lowest titer is 1 to 160. Those are dilutions at which the neutralizing antibodies are tested. And certainly the person's general overall health. Are they a good plasma donor? Their age, their comorbidities. Are they on a lot of other medications? Are there other things that they are taking? Do they have any habits? Do they have any other health risk factors? All of these factors are taken into consideration to know for whom being a plasma donor. But I would certainly encourage people who have had the infection to look into their local hospitals and local COVID care hospitals and centers to know, because certainly plasma donation has been one of the plasma infusion, convalescent plasma infusion has been one of the most effective forms, because you're directly giving ready antibodies to the person, and their immune system can then quickly opsonize the virus and the virus parts and remove it from the circulation and reduce the infection, the viral load, the replication, and make a big difference. So that certainly is a silver lining, and one that needs to be it's again a personal and social responsibility. People need to come forward with that once they get better, recognizing that it's a blessing that they got through the infection. They are in that 90-95% group who made it without losing their lives and or having severe disease, and certainly they can go a long way in helping others out too. And convalescent plasma can be actually even donated once a month, depending on the health of the person in some ways, whereas blood donations happens once in 3 months, because we are putting the packed cells back into the body of the person. In certain situations, we can, if we fractionate it and give it back, if the person wants to give the entire thing, that the red cells are used in one place, the convalescent plasma elsewhere. But it can be done frequently also for a relatively healthy person who is on a good diet, good lifestyle, and otherwise healthy.
Thank you. 2 months ago, I remember asking this question through a chat, saying that when you were finishing your webinar, is there a POC test for antigen antibodies? And at that time, we didn't have it. Do you think today we have a very reliable point of care test where, as dentists in our clinics or for our staff members, we can go for a POC test before treatment?
Certainly. So point of care tests have been around now since they were available in other parts of the world in April. They came to India only in May. And the initial antibody test that came in from around 8 or 10 different sources, many of them were later on found not to be as sensitive and specific, and many of the batches were returned. You must have read that even in the public domain in news media. But now the tests that we have in August 2020 certainly are very good tests that are available, both for antigen detection and for antibody detection. I would like to here again share some slides and take you through some information that will really help you all understand these factors a bit better. Um, so with the antigen and antibody tests that are commonly available, when we look at antigen tests, there is one that is being used by a company called SD Biosensor. They are an international company. Their kits are available in India. This is a test where through a rapid chromatography immunoassay done with, again, a nasopharyngeal swab. So this is not a blood test because you're trying to pick up virus particles in this test. So you're picking up the spike proteins of the virus and certain other nucleocapsid proteins, depending on the different tests that are available. And you bind it to antibodies that are on the media in which you place the sample. And through that, you get results within 30 minutes. Now, what has happened with the antigen test is it is very much user dependent. What I mean by user dependent is the way in which the sample is collected determines whether the test will be successful or not. Okay. And because of that, if the sample collection happens to miss the area where the viral antigens are, you'll get a negative test. And this was the biggest issue because of which initially when it came into India, they were finding pickup rates of only 50 and 60% of these antigen tests. But it is now being very widely used for community screening to diagnose the infection early and in the acute phase, because it can be positive as early as the second or third day of infection when the virus shedding is at a high level and a disease can be transmitted. The downside being, if the test comes negative and your level of suspicion is high of an infection, you're still required to do a RT-PCR, the nasopharyngeal swab RT-PCR, which is still the gold standard of testing. So that is where the antigen test starts. It is more for diagnosis of early and acute infection, and it is being used. That's one of the reasons why the number of cases in India has gone up so rapidly, is because these antigen tests are being done, which very quickly diagnose people. Many of these people may have a mild or asymptomatic infection, but they're in a high risk zone. And I'll tell you what the pros and cons are of doing that test. When you come to the antibody test, there are two types of tests in the market, and I've given an example of both. The ones that first came were the IgG and IgM antibody screens, and that's the one on the bottom of the screen. An example is ImmunoQuick. There are several other brands that are available. And what these do is these pick up the IgM and IgG antibodies specific to SARS-CoV-2 and COVID-19. Now, when you look at these tests are ideally meant to be done around the globe. This is not my information. This is standard, that they show the best sensitivity and specificity around day 14 onwards after the infection. So they are really not meant for diagnosis. They are meant for disease surveillance and epidemiologic studies. Now, if you have IgG and IgM, you're picking up two of the specific antibodies. If you add IgA to the mix, you have a higher chance of picking up the antibodies that may be developed or produced by the virus once it has been in the system. Now, IgA and IgM are detectable in the first week of infection. IgG is usually detectable in the second week onwards of infection. And as I said, the best sensitivity and specificity, which any test can say, are all at day 14 onwards. They are not at day 5, they are not at day 7, they are not at day 10, they are at day 14 onwards. And so when it comes to identifying whether someone has been exposed to the infection, whether that person has possibly had a mild infection with a scratchy throat, an itchy throat, maybe a little body ache, a little malaise, and they got well, whether it was a COVID infection, certainly these antibody tests can be very beneficial. And I'll just go through some slides which will clarify this further. So SARS-CoV-2 antibodies are present approximately 2 weeks after the infection starts. And remember, the first 4-5 days of the infection, symptoms may not be present. If a specimen is collected too early, the antibody test would be negative. A false positive can occur if you pick up the older coronaviruses, as I mentioned, but the chances are far less with the new tests like the ones I showed. The false positive can also be the result of low prevalence, even when the antibody has a greater than 98% specificity. To reduce the likelihood of a false positive test, the Center for Disease Control suggests that if you have one positive antibody test, you should then repeat a second different methodology antibody test for confirmation. And by doing that, you can actually increase the chances of the accuracy of the test. The real purpose of these antibody tests is what we call serosurveillance. Serosurveillance means you're conducting potentially random antibody sampling in health and industrial workers, office staff, general public, where the health bodies, the government bodies that are doing studies can estimate the true level of exposure. So this was done, for example, in Wuhan, China, where after the acute phase and all the cases came down, they wanted to know how many people might have had a asymptomatic or mild infection, never got tested. And what they found was that the number of the population that had antibodies was around 5%. So that is very relevant because we know that herd immunity is between 60 to 70%. Same way, if there are a lot of hot spots where a lot of cases are being detected, and there if you do antibody surveillance, you may figure out more cases. And that is why the cases in India are rising, because the antigen testing are being done in the hot spots, and the hot spots are picking up more cases. But many are mild or maybe even very mildly or asymptomatic. So public health decisions can be very, very useful in estimating transmission rates, case numbers, and allocating resources in a better way. With regards to the antigen testing, people have even spoken about doing this door to door. Obviously, that's not how we recommend. Spot testing in doctors' clinics, daycare, home care, this is not something that is still approved to be done. It is still being done through valid agencies, labs, and doctors' offices that have the background and the training and the experience to do testing and work. Unless it is being done by a doctor for themselves, for their own self and their own staff, for a screening or analysis or serosurveillance. Again, the antigen test, as you can see, has a sensitivity between 60 to 90%, whereas the antibody tests have specificity and sensitivity above 98%. So 98 to 99, 100% is what they have. Identifying the asymptomatic carriers and infected individuals will help take them out of the general population and keep them in self-isolation so that they don't spread it to others, which will make a difference to the ultimate disease. One last word about the antibody test. There was a Cochrane review which looked at 38 antibody tests from 4 different countries, which looked at similar types of antibody tests that were approved by the public health agencies. And what they found was during the first week since onset of symptoms, the sensitivity was 30%. In the second week, it was 72%. And in the third week, it was about 91%. Now, these are tests that by themselves, on the study, on the analysis of the test itself, have 98 to 99% sensitivity and specificity. But used in a real life scenario, this is what was found. And so knowing who has maybe had it, gotten exposed to it, done and gone 14 days, 12 days, 15 days, 18 days, 20 days after the antibody test screening may be worthwhile to follow and check and know what is happening, especially for healthcare workers and people who are in the front line. There is a compendium of instructions for COVID-19 testing that I would suggest people who are actually thinking of doing this to review. The first 12 pages is relevant. The latter part is all the approved labs and all those lists. This is for the government from the government of Maharashtra. the Medical Education and Drugs Department, it's worth reviewing for anyone who truly wants. And there's a lot of data on the Ministry of Health and Family Welfare website also, if someone is interested in knowing. To make a long story short, I would say that for people who are thinking of using this because they work in a high risk scenario, because they work in a lab, a hospital, a clinic, it can have its value. It is not a diagnostic test, the antibody test I'm talking about. It is more to know whether the disease has already happened and gone. Are you potentially immune and protected? Should people be doing, because these are not quantitative tests, these are qualitative tests. They just give you a plus or a minus, yes or no. So you can't use it for repeated testing to know whether your immunity has waned. That's not a very smart way to do that, because you may still have some antibodies, but it may not show up on the point of care test. So it should not technically be used that way also, in my opinion. But there are people who suggest there are ways to use it that way. I really leave that up to the person's reading and talk to the people providing the test and the accuracy and all those things. There are tests that give you the IgM and the IgG separately. If the IgM is positive, it still means that the infection was recent. If the IgG is positive, it tells you that the infection was a little older. If the IgM is negative, so there are specific interpretations. If you have a test that clumps IgG, IgM, and IgA together, then you know that that test will only tell you whether the infection has happened and gone. It can't give you the differentiation between recent or old. So all of these factors have to be taken into consideration, and certainly the options are there in the market. The CoviScreen test, as has been mentioned, has the advantage of an extra antibody, what we call a double antigen test. All of these point of care tests are what we call lateral flow analyzers, because you put the blood and the sample or the tissue into the well, and then you put the diluent and it spreads the blood along an antibody surface and gives you the result within 15 to 20 minutes. And it's quite efficient, effective. I have certainly used them in my practices for patients who I suspect have had it and gone. And the results have been helpful and useful in counseling them, guiding them. But I don't do it as a routine test. It was only when it was done as a pilot, as a trial, we were seeing how the tests work. But that's really up to each individual practitioner how they wish to use it in their own practice for themselves and their staff.
Yeah.
Or, as I said, serosurveillance.
Okay. So I remember when CoviScreen came into the market, Sir was one of the first one who got tested with it, and it was, I think that was around 1st of July, sir.
That's correct.
And you were hospitalized between 1st to 10th of June, right? And yours was positive. Then I got myself tested, and I was back of the mind, I was hoping that it comes positive. I've already had a silent encounter with it, and which I don't know of. And it was asymptomatic. Unfortunately,
one of the very few tests where you start praying that you're positive.
I swear, I did that. And it was
the infection, exactly. It's after the infection. We want it to be positive, so it's done and gone.
Fortunately negative.
You so beautifully laid out the entire topic of today's.
Yeah.
So I think it is just about time that we ask you for this final opinion, not exactly a question. We are seeing a lot of, should we say, reduction in the IFR for sure, infection to fatality ratio. But more importantly, people are opting for home quarantine based on their tests or symptoms. So what is your take on this? Is it an encouraging trend, or are we missing the trees for the woods?
So, Dr. Kumaraswamy, I was actually in favor of home quarantine and home care even back in the month of March and April when I was giving television interviews on various channels. Because some of the countries, and we've spoken informally about this, I've spoken to you all yesterday, like Germany and other parts of the world, they had actually taken this on so that their healthcare system doesn't get overburdened. the milder cases, the cases that do not require oxygen, the cases that don't have any significant respiratory problems, they can be very well managed at home. And with being in your own home environment actually takes away a lot of anxiety of the person also, takes away a lot of the stress also. The risk to home quarantine and home isolation is obviously cluster spreading. So you spread it to your family members by living in the house. Okay. So there it becomes very important. Do you have an isolated, a separate room to yourself? Do you have an attached bathroom? Are you using a common bathroom? Can that bathroom be cleaned and sanitized very sincerely by every other person if it is a common shared one? And in these situations, it becomes a personal decision whether you go and live in a place where you keep your family safe and you stay there for 10 or 14 days, depending on when your test comes negative, or you're afebrile for at least 3 days, and then come back home, or you do it at home. But I believe that the more we can do at home, the better. We know that we have to monitor people's pulse oximetry now, which we didn't know 3-4 months ago.
Yeah.
We know that if the pulse oximetry drops by greater than 4 points, even with the person walking around the house, we know that that's an ominous sign that the person may get worse. We have a lot of information now that I truly believe cases can be managed at home safely, provided that there is a healthcare provider, provided there is a healthcare professional who is constantly monitoring and in touch with the patient, and whom the patient can get in touch with and get guidance, preferably along government given guidelines and rules and regulations. And with drugs like favipiravir, which are even being studied for prophylaxis. So when oseltamivir came out for influenza, it was first for treatment of influenza. Later on, it was found that you can give it to the close contacts of the influenza patient, like the family members, for 10 days, and you could prevent the infection in them. Favipiravir is also being studied like that. It's not yet approved, so don't take it. I'm saying it, so it should be taken by the family members. It is still in works, the research. But favipiravir works both on influenza and on COVID-19 infection. So it's a double sword. It was originally approved for influenza in Japan, and later on it was repurposed and found to work for COVID-19 also. So with these drugs being available, with therapies being available, I do believe that home quarantine and home care, home isolation, self-isolation can work along with all the precautionary measures and care that are required by the family and the caregivers of the person who have the infection. And at the earliest sign that there is any worsening, a fever that won't remit, or a fever that went away and then came back around day 7, 8, 9, 10, or with respiratory symptoms that progressed, or with pulse oximeter readings that reduced, or with other features, because we know a lot of people are getting cardiac arrests and heart attacks in this time frame with COVID-19. We get a lot of people who are having other comorbid conditions getting worse. Diabetics are having their sugar go very, very high during this infection. So there is a lot of monitoring that will be required depending on who the case is. But otherwise, healthy adult without too many other complications or problems can certainly be well managed at home, in their home environment, with the safety and security of their own people around them, with the right medical care and guidance. So that's my take on that.
Thank you. I think it's been splendid. Really fantastic 90 minutes with you, Siddesh. And I would now ask Ajay to take any questions if any viewers have asked.
Oh, there are ocean of questions, sir, because pardon me if I have to take at least if I take question for 15-20 minutes, because people will not let me go. And I typically see, if I don't take their questions, I start getting phone calls during the webinar or the
you'll get threat calls. Go ahead. My time is yours.
Yeah, thank you so much for that. And one of the question is from Dr. Mahesh Gavde, and he asks us, will it be helpful if we tell our patients to do at least antibody tests before dental treatment, as RT-PCR for each patient is not appears to be feasible? So do we, as a dentist, do we tell our patients, and now these are the rapid tests that can be done in the clinic, it's just a prick. So do you think we should be taking, or we should be selective about it? Like we ask patient the history, and if he gives us some tentative history, which is directive towards some respiratory infection, then only we do it. How do we go about it?
So antibody testing for screening patients is really not something that has been, to the best of my knowledge, recommended or done anywhere in the world for two reasons, as you can imagine. Okay. You may get a negative antibody test and it tells you nothing whether the person is in the pre-symptomatic phase of their infection or they are one of the false negatives of the test, which is very much possible. Okay. Now, if the test came positive and you know that the person possibly had the infection 14 or more days ago, it can at best tell you that this is someone who has recovered or is recovering. It does not tell you anything about their viral antigen or viral shedding, because there have been cases where viral shedding has proceeded beyond day 14 of the infection, up to day 21 or even day 28 of the infection. Now, whether all the viral particles were genuinely infectious or not is an area of debate and research that is going on. So, antibody tests for screening patients is not a good option, in my opinion. The antigen test, because that picks up infected individuals who can give the infection to someone, might still be considered as an option because you're picking up acute and early infection through the antigen testing. Antibody testing, as I said, so far is purely a serosurveillance. Now, if you have a patient who says, 3 weeks ago I had fever, body pain, I don't know whether it was a COVID infection or not, and they have a curiosity, you have a curiosity, and you do the test, it will be a purely curiosity sake test. The rules and regulations governing that is for each individual practitioner to see, because again, my understanding is even if you do a point of care test, in order to give a report to someone, you need to have certain lab kind of associations or those kind of things. So you can do it for the sake of knowing whether it was there or not. But I am not aware how it would help you in reducing your risk or enhancing your safety when you're treating that person. In that, taking your precautions is the best bet. Using your face shield, your mask, your PPEs if you feel it's required, depending on the procedure, your rubber dams and all the other stuff, you all know better than I do. But even if you make the patient do an RT-PCR, the RT-PCR has a 70% sensitivity. You can still miss 30% people who have an infection. So there is no perfect answer in this scenario. And that's why, again, I say the same thing I said at the end of my last webinar: work on your own immunity. Keep yourself in the best of shape and pray before you go to work, pray before you see each of your patients, and pray when you come back home healthy and you wake up the next day with a prayer that you're healthy and your family is healthy. That's really all you can do right now.
Absolutely. So there is a question from Dr. Debashish. He says that, is there any prophylaxis treatment to prevent cytokine storm? For the viewers, you can probably tell what is cytokine storm in
brief. Yeah, sure.
Yeah.
So while the body is fighting the virus off, somewhere between day 8 to 12 or day 13, sometimes the immune system overreacts and overresponds and doesn't know when to stop itself. And there is such a large release of the same cytokines that are invaluable in fighting the virus, that now it becomes detrimental to the person's own immunity and cells of the body, including the lung cells, the kidneys, the heart, the liver, the other organs in the body. And in a cytokine storm, which is a dysregulated or an unregulated immune response, overactive immune response to the virus, you can actually cause damage, not by the virus. The viral loads may actually be going down, but by the response of the body to the virus itself. So in these cytokine storms, so far, to the best of my knowledge, identifying the cytokine storm early through the D-dimers and the IL-6 levels, etc., and using the anti-IL-6 or the anti-IL-6 receptor antibodies early on seems to be the only way to avoid it. The question whether using remdesivir, that's the only antiviral drug that we have right now. I know that there is all this, favipiravir is more for mild to moderate. We are still waiting for data to know whether using favipiravir in the mild to moderate will prevent the cytokine storm or will prevent people progressing to the higher stages of the disease. But those are areas that we don't have an answer. So the only other drug that has had benefit, and I'm sure you all have heard in media tons about it, we were using it long before the study on dexamethasone came out from UK, and UK was touted as finding the cheapest drug for preventing, or overactive immune response, and using dexamethasone. We were using prednisolone and methylprednisolone even before they came out with their DEXA study. And steroids are a drug that, if they are given at the right time, when the patient is progressing from mild to moderate, or potentially from moderate to early stages of severe, you may prevent the cytokine storm. So, getting the antivirals on board quickly and using steroids seem to be two ways, but there is no perfect prophylaxis that I'm aware of at this point of time to prevent the cytokine storm. And once it is beginning, the tocilizumab and the itolizumab are the two drugs that can help.
Absolutely. How interesting it is that usually what we have studied generally in viral infections, you avoid taking steroids because that reduces your immunity. And we suddenly come to know that, okay, in this particular type of viral infection, if you take steroid, it can be helpful. Of course, at the right time, not as a general cover to begin with, but if you are getting into that phase of cytokine storm, it certainly can help you.
I'll share something with you, Ajay, and this is where our experience as allergy asthma specialists was invaluable for us. So when the WHO came up with that statement that steroids can be detrimental in the treatment of COVID-19 because it may suppress your immune system, they came out with this in March and April before the DEXA data came out a week or 2 or 3 weeks later. We as asthma and allergy specialists, we see patients and I've been seeing now for 20 years, patients who come with a viral exacerbation of their asthma. Asthma is an inflammatory disease. Okay. You get a lot of cytokines released. The virus triggers the inflammation. The person already has inflammation due to the disease. The first line treatment for a viral induced exacerbation of asthma is steroids. And we've been using it since the 80s, whether in the inhaled form or in the oral form or in the IV form.
That's right.
So we knew all along that if you use it in the right dose, you don't overdo it. As they say, har cheez ka ati जीवन में खराब होता है. Excess of anything is bad. Okay. We knew that if you stay within the 1 milligram per kilogram body weight dose and you give it at the right time, you can actually help the body not overreact to the virus. And so I never stopped using steroids, though the WHO had come out with its guidelines. I never did, not once. So, and later on when the DEXA thing came on, people realized that, because the concern was when people read the steroid word, many asthmatics stopped their inhaled steroids. Many people who were on allergic rhinitis, nasal steroids stopped those steroids. So it became so counterproductive for them to come out and say that steroids can be suppressive because people don't differentiate between different types of steroids. So I think here is where, again, they should have gone with experience rather than a knee-jerk reaction, which I have seen a lot of knee-jerk reaction in these last 7 months, I must tell you. Okay, this works, remove it. That works, remove it. Now this works again. It's like, I don't know.
Military approach, as I say, you keep using anything and everything, something may act.
Yeah.
The military approach.
So one of the knee-jerk reaction question I'm going to take the next is, what is your opinion about role of hydroxychloroquine and ivermectin in the scenario of COVID? Meaning it's been time to be, not to be. It's been we have really heard a lot of things, especially about hydroxychloroquine. So what do you think about these two drugs?
What I'm going to say, I'm going to qualify by saying, because I know that there are national and local guidelines on the use of this. This is my personal opinion. Please do not follow it. This is my experience and opinion and my study of the field that I'm talking about. Okay. So I was one of those physicians who never took hydroxychloroquine prophylaxis because I have, as an immunologist and as a person who treats autoimmune diseases, seen the side effects of that drug used at higher doses and for prolonged periods of time. I completely understand. But I felt that the data and the science behind it wasn't as strong as I would like it to be. Now, there were many colleagues of mine who did take it because it said it's such a small dose and you take it once a week, and they've taken it for 8 or 9, 10 weeks now. And initially, the data came out that there was a cardiac risk. Then the data came out that the people who published the data on the cardiac risk were all industry funded people who gave out wrong data. So everyone thought that it was bogus and they should use the hydroxychloroquine. And now, most recently, literally within the last 10 days, someone has done a very smart study where they have looked at elderly individuals above the age of 50 who are on multi drugs. And many of these drugs do have an effect on the QTC interval of elderly individuals above the age of 50, where if they are on certain of those medications and you add azithromycin and you add hydroxychloroquine with those drugs, you can actually extend the QTC to up to 500 milliseconds and put them at risk for arrhythmias. So the truth lies in between who uses, when they use, how much they use. The data in the trials, the WHO stopped the trial in which they were using hydroxychloroquine because they felt that it made no difference to the end outcome of the patient. So hydroxychloroquine for prophylaxis, hydroxychloroquine for treatment, the data is not at all that convincing to me. Again, this is my personal opinion. There are big groups and organizations who believe the data is convincing. Very recently, this is anecdotal information, this is not research. We have an association of medical consultants in Mumbai called AMC Mumbai. They did an informal questionnaire for the survivors of COVID amongst the doctor community. Okay, 176 doctors responded. Out of those 176 doctors, 69% were taking both hydroxychloroquine and azithromycin in their treatment, and many of them, up to 76%, were taking hydroxychloroquine as prophylaxis. Okay, so despite the prophylaxis, they got the infection. Now, this is one closed community that is a high-risk community, heavy exposure, constant exposure, but whatever that means, if 76% of the people who were taking hydroxychloroquine still got the virus, I leave it up to you how you interpret that data. Okay, I'm not going to judge it. I have given my personal opinion. Now, coming to ivermectin. Ivermectin, again, has been a drug used around for parasitic infections. There have been drives done in African countries and other countries to give it to people to wipe out viral loads, wipe out parasitic loads in them. So, time-tested drug. There are some proponents, especially in Australia, who strongly believe that a combination of ivermectin with doxycycline and zinc has 100% success rate in COVID. These are anecdotal, individual physician experiences. This is not a study I'm quoting. So studies are going on. Those studies have to be waited for and looked at. I would also be keeping an eye on those studies, whether to use them. So whether to use hydroxychloroquine with ivermectin, whether to use hydroxychloroquine with azithromycin, whether to use ivermectin with doxycycline and zinc, whether to use any of this combination with zinc, vitamin C and vitamin D is really all up in the air, is the best I can say. And I'll again say one thing I said in my last webinar, placebos work.
Yes.
Always.
40% people in a clinical trial get well in the placebo arm in diseases that are real diseases. Yeah. So even if a person takes with full conviction a sugar pill that they are taking something for their problem, whether you call it the hand of God, you call it divine intervention, you call it your own mind and your subconscious mind, or whatever you want to call it, it works and helps you get better. So I would say that every physician has the responsibility to keep up with the data. We have data for favipiravir, we have data for remdesivir, we have trials going on for them. Same way, look at the trials, keep up with the literature. Right now, I am sticking to drugs that are tested, that have shown results in trials, and using them in treatment. I am not using for things that a small group of people doing what is called a case control study. Case control is not a placebo controlled trial, and you can't base judgments based on that. That's just my personal opinion. I'm not saying that it is wrong or right. Like I said, if you took hydroxychloroquine like it was rak given by Sai Baba, you can get well with it also. It's your faith that will get you well. I don't know about the drug. But if you're an elderly individual with multiple medications and you're given hydroxychloroquine with azithromycin, please look at the drug-drug interaction before taking it, because there have been cases and there are studies showing that it can prolong QTC interval pretty significantly.
Okay. So there is Dr. Vidya asking us, if I have to do antibody test, which one shall I prefer? Shall I prefer IgG, IgM, which is enough, or I should prefer something which is Ig, IgG, IgM? As you mentioned, Coviscreen is with IgA. How does it differ in both of them? Meaning, IgA will give me early detection, or only IgG, IgM is enough?
So as I said, when you look at the sequence of production of immunoglobulins, IgM is the first antibody to be produced. IgA can be produced, but their timeline is very similar. Somewhere around 3-4 days, 5 days is when both of these start getting developed. IgA also increases in the second week, IgM also increases in the second week, and then they start declining before IgG becomes the prominent antibody. If you go by the principle of more the merrier, okay, then it would seem that having IgA in the mix with IgG and IgM seems to be an added advantage. And you're able to pick up more in case by chance that person tended to have a higher IgA response. So you have to remember that in blood, IgA is primarily highly concentrated in the mucosal surfaces. So in your respiratory tract, in your GI tract, it is not highly concentrated in blood. Highly concentrated in blood are IgG and IgM. That's a fact. We know that as immunologists. So for whatever it is worth, having the IgA in the mix is an advantage. But I do believe that the IgG, IgM test also in any of these done around day 14 can give you reasonably good results. If you're doing it early after exposure, the IgA has a little advantage over the IgG and IgM. That's how I would put it. But it's still for serosurveillance, not for diagnosis.
Yeah. So I have a couple of real life experiences over here. One of my very close friends who practices in Mumbai, and he himself is with some comorbidities. He at early age he went to a bypass surgery and all, and he happened to have some history with one of his patients, dentist friend of mine, and he did Coviscreen test, turned out to be positive. And that was kind of a alarm for him. Okay, you inform the patient it has been positive, and an alarm for him also that he has to be more careful. Of course, he takes all the precautions and all, but in spite of that. And then there's second Dr. Rajiv Chitgupi shared me couple of reports of one of his friends from Belgaum. His father was admitted and he did Coviscreen test. After he coming back home, actually it was antibody positive, but this dentist himself did it for himself, and it turned out to be negative. So probably he's still not. His father had infection, hospitalized, but he did not get infection. So we can get some information, but as you said, that is not ultimate. That is not final. Meaning it doesn't conclude everything. There's no one single test which can conclude everything. Absolutely. I will go little off track and ask you a question. That is one of Dr. Ganesh says that is using sanitizers frequently can cause any damages to normal commensal microorganisms?
Yes, it can, unfortunately. And we are seeing more and more people with hand dermatitis these days because the natural bacterial flora that we have on our skin is all getting damaged. The natural barriers are all getting eroded. And because of that, the chance that chemicals or other substances or infections like fungal infections, potentially, I'm not seeing a lot of fungal infections, but I'm just giving the possibility that as you remove the bacterial load along with the viral load, you enhance the chances that you may get other microorganisms which are around us naturally causing problems. And certainly the irritant nature of certain sanitizers, okay, if used very frequently, does cause what we call contact dermatitis for a lot of people. So while the commensals, yes, can get wiped off through very frequent use of the sanitizers, and that's why for people who are in professions like dentistry, using gloves and changing gloves makes a lot of sense, which I'm sure all of you all do in your practices, because then you're not directly always and using soap and water for washing, and using a gentle soap which has certain moisturizers which is pH balanced to protect your skin with a pH of 5.5. All these are very important to protect your skin barrier and your commensal. But when it is needed, it is needed. You have to use the molecule. You have to use the sanitizers to protect yourself. There's no doubt about it. But be careful. Be careful.
Okay, taking this question forward, I was just thinking that we've been super protected right now. We've been on best. We are trying to boost our immunity like never before. We are at home most of the times, well protected within walls, whenever required under AC or whatever. Meaning very well protected. We are not exposed to the outside harsh environment, including pollution or whatever. We are not meeting people, so we are not catching any of those routine infections nowadays. You speak to medical practitioners, they will they will tell you that there is practically no disease in the air. Minimum flu which you normally see, or diarrhea is not there, which usually starts with monsoon, right? So once we go out after we have a vaccination which is available in abundance and all, once we start moving out, once we start meeting people, is there a chance that we will catch up infections very fast because our immunity is not being trained, or those mild attacks which we used to get are not there anymore?
There is no data to suggest that if you don't get other infections, your potential to respond to an existing infection goes down. However, if you look at the West versus the East, where the West has much less of gastrointestinal illnesses and viruses and bacterial infections, and East has more, this was one of the theories why they thought India had a lower death rate than Italy or Spain or US, because they felt that we see so many bacteria and viruses in day-to-day life through all the change of seasons and with all the overcrowding that we have, that maybe our immune system fights off this virus just like it does other viruses and doesn't get too affected. Whether this will happen or not, Dr. Bajaj, is really speculation at this point, and I'm not a speculator, frankly. What I will tell you is, if you take this time, I said this in the last webinar also, if you take this as a time of where you've been blessed with time on hand to exercise, to eat well, to eat right, to sleep well, to do your walking, do your jogging in a safe way with your masks on, to keep yourself healthy overall, then it doesn't matter when you go out from lockdown and you start doing all the routine activities, you will respond to the virus no matter what. This had been said by WHO very early. I said it in the last webinar. आज नहीं तो कल सबके पास ये वायरस आएगा. Option ही नहीं है. Circulate करने ही वाला है. There is no option. So the question is, yes, we had to delay it so that we could get the right drugs, we could get the right treatment protocols, we could prepare the hospitals with the ventilators and the ICUs, we could get the doctors smart enough to treat it ourselves, we could get everything done. But at some point, जीवन जीना पड़ेगा, ऑप्शन नहीं है. और ये टाइम आ गया है. मेरे हिसाब से ये टाइम मई में आ गया था जब मैंने सारे डेंटिस्ट को बोला, बाबा जाके प्रैक्टिस करो. मैं आज भी वही बोल रहा हूँ, जीवन जीना मत छोड़ो. जितना बचे रहोगे, जितना ककून में रहोगे, उतना you are delaying life, the process of life. We all need to get back. It's going to be life with certain restrictions, with certain precautions. And here, I would like to share one slide with you all.
Yeah.
If you give me the opportunity, I'll just see if this shows up. I had put this up here for a very specific reason, and I think if you all get the message that I'm trying to say in this, it would be very beneficial. Again, it takes a moment for this to start moving once I project it. Okay. I call it the current disease burden. So globally, there have been 21 million cases and about 7 lakh deaths and about 13 million recovered. India is now 25 lakh plus positive cases, 49,000 deaths. In perspective, just by road traffic accidents in 2017, there were 147,000 people who died. These were people who were not going to die otherwise. They died of a artificial, man-made, or whatever you want to call it, accidental death. Okay, 3 times, almost 2.5 times more than what COVID-19 has done in 5 to 6 months. And look at the economic impact of what has happened in those same 5 to 6 months. TB kills one person every few minutes in India, but we never talk about it. We don't get home quarantine. We don't do all these things. So I want you all to really ponder upon these things and look at what is it that is really happening? What is it that we are doing? And where should our focus be? And is our focus in the right place? So certainly, and I'm giving only minimal statistics. If you take the statistics for dengue, for malaria, for this, that, and everything, you're talking of a minuscule number of deaths. But I know that it's bad when anyone dies. We know we've lost doctor colleagues around the country, around the world. We've lost healthcare workers. We've lost all kinds of people. But at the same time, somewhere we have to take this in perspective and realize that this thing can't stop us from living. Life has to go on. We have to move on. We have to do our work. We have to live our lives, and we have to get back to some semblance of normal with a new normal set in what we do.
I think also the later you get afflicted, the better, because by which time the understanding is clearer, we have more options for treatment, and also probably the virulence will drop down. There's no guarantee, but
there's no data on that.
Exactly.
No data. Viruses are very smart. They only increase their virulence. They never down-regulate their virulence. There is no virus that I have known ever which has down-regulated its virulence, because it only wants to infect more and more new hosts. And there have been point mutations in spike proteins. There have been point mutations in nucleocapsid proteins, and all of them. So the Wuhan virus is very different than what Italy and US and now India is seeing. It's a different breed of virus. 97% of the virus in the world is not the Wuhan virus anymore. It's a higher, smarter, better virus. And that's the fear with vaccines. Tomorrow we'll have a vaccine and the virus will mutate itself.
Wily. It's a very wily virus.
Yeah. And these mutations are so common, meaning that's how we have to take influenza vaccines. We have to repeat it
every year.
Exactly. Because there is mutation with other viruses, and there will be mutation with this virus too. So probably this vaccine is going to.
But the good news is it's a slow mutating virus. It is not as fast as influenza. So I want to leave you all with a positive thing. It doesn't mutate as fast as the influenza virus and some of the other viruses. It is a very slow mutating virus. So that's a good thing. The worrisome part is there are 500 coronaviruses that are found in bats. They have been studying it since 2002. There are 500 variants of coronaviruses in bats known in China.
Hitesh, you said you were leaving us with some good news.
Good news is your immune system can handle 500 of them, is what I'm leaving you with. Trust me. You can handle all 500. And they are not going to come out that easily. They require a lot of things to happen. The cycle has been, I don't know what it is. The cycle has been pandemic 100 years and epidemic 10 years. So I think till probably 2030, till something major, because even when you have a major antigenic shift that occurs in influenza, you get an influenza pandemic about every 7 to 10 years. Okay. So the answer to the game is the same thing. I'm like a broken record. Work on yourself, work on your own health, Work on your own lifestyle, your diet, your immunity. Get back to your roots. And then it doesn't matter whether it is Nipah virus or Zika virus or COVID-19 or SARS-CoV-2 or Hanta or Ghanta, whatever it might be, excuse the language, you can get over it. That's the key.
I always say, if you really wanted to exercise, and previously you always complained that you did not have time, and when you have time now, everybody's workload is like change, reduced, and if you still don't exercise, you never want
to watch web series.
You never wanted to. You're just waiting for the vaccine to come and save you. That's not the correct way.
I think on that note, Ajay, I think we should thank Dr. Sitesh Roy
Yes.
and Sensodyne and everybody for this wonderful Sunday morning / afternoon session. And if you need to sort of wind it up, Ajay, thank you so much, Dr. Sitesh Roy.
Yeah. Thank you, Dr. Sitesh Roy. Thank you, Kumaraswamy sir. And I think it was a fantastic session. I've got so many messages, people thanking, and I think people will keep seeing this session again and again in near future. Thank you, Dr. Sitesh. You were wonderful as always. Thank you so much. Thank you.
My pleasure. Have a blessed day. Thank you. Take care. Bye.